Hi, everybody. This is episode 92, our second episode of season 4 of our podcast, Artificial Intelligence and Cybersurgery, the official podcast of our journal, Artificial Intelligence Surgery, the first and possibly only journal dedicated exclusively to artificial intelligence and surgery. My name is Dr. Andrew Gums, and I'll let my co-host, Dr. Vincent Grasso, introduce our next guest.
Yeah, thanks, Andrew. It's exciting. We're in season 4. It's moved pretty fast. And Gary, it's a great pleasure and privilege to have you on today. And thanks for taking time out on your Saturday to join us. Dr. Rhule is the medical director of the Public Health Clinic in Hartford, Connecticut, for the city of Hartford. He has a very interesting background, and we're looking forward to learning more about what you're doing up there, Gary. And please introduce yourself a little better to our audience than we have. Welcome to our podcast.
Yeah, Gary, this is the part of the podcast where I always jump right in and interrupt you before you can even say anything, because I would like to talk instantly about your background and kind of how we got into contact. And what I mean by background, I mean literally the thing that we're looking at behind you. Okay. Like, so maybe we can talk a little bit about the Caribbean, the Caribbean.
Oh, no, certainly. No, certainly. Okay. Well, thanks for having me on. Um, in terms of background, I was born in Kingston, Jamaica, came to the US when I was 15. I came to New York first, then went to Hartford, Connecticut, finished high school, medical school, college in the US. But when I was in med school, I did a rotation at Bustamante Children's Hospital in Kingston, Jamaica, where I met a colleague of yours or a friend of yours, Dr. Edwin Tuller Reed. And we've kept in contact through the entire time that I've been working through training. He was in New York. We've kept in touch. And I was talking to him recently about my interest in AI in medicine, predictive modeling, what's being done on the medical side, what's being done on the surgical side. And he says, I have a person you need to speak with. And that's how we kind of got connected.
Great, great. What type of doctor are you, Gary?
So I'm trained as an internal medicine physician, but never practiced that. Did emergency medicine for about 25 years, did a public health degree, did also a degree in business, and then worked for an insurance company, worked in managed care, and worked in public health. Great. So really I've kind of done a couple of different things. What I'm trained in never really did as a clinical physician, really did emergency medicine for a long time. I also did a year of anesthesia. I loved it. And then really just because of the strain of emergency medicine, because I was working 12-hour shifts really all the time, all the holidays, all the in the weekends, I wanted somewhat of a change. And so that's how I came to be in this space at this point.
Well, internal medicine and emergency room doctor, the overlap is, you know better than I, is quite, is perfect. I think it's perfect for an internal medicine to be on the contrary, it's you're perfectly poised for that. But it's interesting to me what you just said is I found an interesting statistic that the average age of surgeons, or not surgeons, of doctors retiring in the United States, I just heard, and I'm shocked by this number. Well, before I find the number, at what age did you stop doing clinical work?
So when I was about 50.
Yeah, amazing. So I think I was around 48 when I left the United States and I moved to Europe. So I count as someone who's retired, and you were 50, and the average age is 48. And right when you and I both met, we both met with a burnout. You went into another field. You got out of clinical work, but you stayed in the same field. And I went to a much more humane way of doing medicine. So it's interesting that we're a cliche. Vincent. I mean, I know you're still doing clinical, but about how old were you when you stopped doing surgery?
Yeah, about 15 years ago. Yeah, I was in my late 40s.
Yeah. But it's a shocking number to me that 48, like I'm shocked by this number. But the burnout rate, I see all these people on Instagram who are changing fields, and AI, it's kind of a perfect segue. People are concerned about AI, and we'll get into all of the concerns. But Vincent and I know you now are huge proponents of AI to fill the gap, to deal with the burnout, to deal with the stress of being a doctor. It's become unmanageable. So, what do you do? What do you do? What interests you the most about AI? Why did you kind of start learning about it, and how do you recommend people who are interested in AI get into it? The reason I mention this is you have an MBA, and Vincent recommended I get an MBA, and I got an MBA. But then you have something that Vincent and I have discussed. Just to finish the story, Vincent and I are doing PhDs in AI right now, but
Okay.
our next step, Vincent, I'm recording it now, so we're gonna have to stick to it. Our next thing that we want is an MPH. So I love that you are on the same wavelength as us. So explain to us a little
Okay.
bit, why the MBA, why the Masters in Public Health, and what doors that has opened up to you.
Right. Great question. So initially, when I did the MBA, I did the MBA and the MPH concurrently. So I went from one to the next. And initially, my thought was because I'm from the Caribbean, and really in the emergency room, I was seeing a lot of persons who were coming in with chronic conditions, and really over 20 years, it appeared as if it really wasn't well managed. So I was really interested in more population health and predictive model, like who's coming in, the conditions that they present with, and how we could actually use a machine to help us do two things. For the community, there's the knowledge, what things are affecting them, how to approach it, how to connect with care. But for the providers, just the database of information to think more clearly about it, and just the decision architecture to get to a decision much faster, to really connect people to care much faster. So that really was my interest, really predictive modeling and the initial population health management. So that's what I was thinking. But really now I'm kind of curious because I think that obviously AI can help with the decision architecture, readmissions, predictive modeling. But what my thought was, but really, well, you are surgeons, just like myself in an ER, we do procedures, right? So can a machine really replace that? And that was kind of what triggered my thought. Yeah, the thinking, the decision, the architecture, yes, they probably could, and they can assist, but how could they really replace a human being? With the surgeons like yourself, I mean, the dexterity, the hand skills, the hand-eye coordination, will there be a point where a machine can actually do that? A robot can do that? And that's kind of what triggered my thought and my interest in AI from really that perspective as well.
So, I forgot to kind of close the circle with, how we got to know each other is my father's from the British West Indies, from Anguilla. So there's obviously that Caribbean link. And what I love is how interested you are in public health, because I know that's something near and dear to Vincent's heart also. And I think all three of us essentially, as you just mentioned, are proceduralists. We're able to treat one patient at a time. And I personally became very frustrated with treating one patient at a time,
Mhm.
right? When there's so many huge problems, I see people, African Americans coming in with very advanced pancreatic cancer, the disparity, and there's so much more you can do than just dealing with one
Right.
on one. And
Mhm.
that's what I love about, your MPH. That's what if you asked me years ago if I would do an MBA, I would have thought you're crazy. But an MBA is one of the most important degrees to get, and it's still the child in me. It hurts me to say that, but obviously I'm kidding. It it is so fundamental. So Vincent, when are we gonna do this MPH? No, but what's your hearing from Gary? Like, what type of things with with his current work you want to ask him about, so we can see kind of how maybe some of the projects that we're doing overlap with him?
Sure. No, I think it's so wonderful to hear Gary. He's still committed to, he's still committed to helping people. He's now in the inner city, probably, of Hartford, and in an organization that doesn't have a lot of funding. Safe to say, Gary, you don't have $100 million budget to go and solve problems. So if you have, say, you have 500,000 people in the inner city that are underserved, linguistically challenged, you've got barriers to reach them for cancer screening, chronic disease management. You have all these barriers, and you need a workforce. Well, a human workforce costs X. A hybrid human digital workforce costs Y. Therefore, AI brings a lot of value to Gary's outreach efforts, that he can't hire 100 humans to make 1,000 phone calls a day and make sure you come in for your mammogram, right? So, the technology used correctly would bring a lot of value to Gary's world, where he can use his cash for things that bring the most value, not just paying people to make phone calls. And that's the opportunity, really, right, Gary, is to make the most use of AI in the practical way.
No, definitely. It can certainly reach people a lot faster, more consistently. And really most persons, right? Some folks don't, but most persons have at least a cell phone, right? They have access to something. They may not have a laptop at home, but really they have some type of mobile device. So you can push reminders to them. You could do health education to them. You can help them maneuver through the healthcare system much better. And really, again, as you just said, Vincent, if you're doing that, you need 100 people, but really a machine can help you do that much faster and more efficiently, and find out where the gaps are, like who's not responding, so you can reach out to them much more in a much better way.
Absolutely.
And on top of that is also the data, right? So on the back end, you have the data analysis that's going to go on, and you can do the evaluation much faster than the human brain could, like 10 people, really. Sure. A machine can do that a lot faster than we could.
So it interests me that you said you worked for an insurance company for about how long?
About 10 years.
So, I mean, you had access to vast amounts of data.
Yeah.
And they have a lot of predicting modeling. That's what insurance companies do. I mean, insurance companies probably been using AI in retrospect, probably before anybody else. Vincent, what do you think? Correct me if I'm wrong. Actually, Gary, you would know. Were you guys using things to help, predict how to insure people, I imagine?
Yeah, I mean, so actuarial science, that's what that is, right? I mean, and it moved from paper to basically a machine. I mean, predictive modeling, that's what it's all based on.
Right. Interesting. Yeah. And then you took that experience, and now you work in public health in Hartford. And kind of, if you don't mind, can you explain to us I mean, my God, I guess we do not have enough time to hear. I was about to say, tell us some of your struggles, but I mean, do you have any like pilot programs or that are using AI, using cell phones, using smartwatches, just like Vincent said, or maybe Vincent I know has a huge interest in this. We could maybe let him suggest some for you, but if you could give us some ideas of kind of some of the problems that you're dealing with now, and then we'll let Vincent talk a little bit about what he does in that space. Following up patients post surgery, working on nutrition with cancer patients and things like that.
Right. So the two biggest places where AI helps actually, or technology helps, would be for persons with diabetes, as well as in maternal and child health, women who are pregnant, families who are pregnant, to be sure that they're engaged with care early. Right. So sometimes what happens, so for like an OBGYN, to be sure that once that person is identified as being pregnant, we give them a cell phone. There's a series of appointments that they need to make to keep. So we text them, your appointment is coming up. These are things you can do to be sure that you remain healthy as a mom. Once your child is born, to be sure they get the vaccinations. And we use a mobile device, a phone, to kind of do that, pushing out appointment reminders as well as health education. So we do that piece. And that really works really well. Because really sometimes what happens with pregnant moms or families, they don't engage early enough with their healthcare provider. And we want to prevent that, because the earlier that they're actually with a healthcare provider, you can identify problems sooner. That's one piece. And then in terms of where I work in Connecticut, um, diabetes and hypertension is also a big problem for many, many reasons. Persons really don't know, what to eat, how to eat, their diet. They don't always remain engaged with their healthcare provider, or when they do, sometimes it seems like it's too burdensome to follow a specific, I'll say, diet, um, physical activity, medications if that's needed. They have a little bit of trouble maneuvering through the system. So again, for the diabetics, and there's a whole um, health disparity around that as well. So we do the same thing with the diabetics to be sure they're engaged, they keep their appointments, health education, they get their kidneys checked, they get their eyes checked, they get their feet checked. And it's just better for the healthcare provider, because if you have a resident and a person who is really just more informed about what they should be doing, it really works well for the person, the person with diabetes, as well as the healthcare provider, and make sure they're connected to the healthcare system. So those two things really, really work well. If we could expand it to the other chronic diseases where we see the problem, heart disease, stroke, hypertension, cancer disparities, it would make a big, big difference.
So Vincent, I know you have tons to say on this topic, but I'm gonna throw two questions in there, but
Sure.
before I forget, number one, is it true they have like an oral insulin now? I saw for pediatrics. I must admit, I think I probably saw this on Instagram, so I didn't verify my sources. So okay, you guys are both looking at me like this, so we'll skip that one. But and my number two thing, which I haven't verified, I saw these doctors at the American Diabetes Association that essentially
Mhm.
got kicked out of a lecture by someone, like an NIH guy was giving a lecture, and they wrote an editorial that got published in like the Diabetes Bible, and they were trying to disperse it, and they got kicked out of the. You guys didn't hear about this? All
I
right.
didn't hear about that one.
All right, so I would have hoped I don't think that was AI generated, but things are getting a little spicy in the United States, where like it seems like doctors aren't allowed to disperse editorials criticizing certain decisions making by certain organizations. I will forward it to you both once I confirm that what I saw was correct. But Vincent, I digress. On these chronic illnesses, I know you've worked, this is your space. So what kind of ideas do you have for Gary?
Well, I think part of the challenge Gary has is there's so much demand, there's so much need, that sometimes stratifying, resources you have with the biggest impact is sometimes kind of difficult, because it's a moving target. Risk is a moving target, and it changes and it's dynamic. So when you try to generate a budget for next year, and you believe you want to do 4 programs, if there's a change in the clinical milieu, or there's different threats, and you're finding different problems in certain populations, it's hard to move resources around. Gary, I had a lot of experience in federally qualified healthcare centers, and they have profound problems with outreach.
Mhm.
And the one in Chicago that I helped a lot during COVID, I just kind of forced them to focus on 3 things. One, mental health topic, out of control diabetes, hemoglobin A1C over 13 and like 8,000 people, and breast cancer screening, where they had people like 10,000 people that weren't screened in 5 years, things like that. And that we declared war on those 3 buckets. And the workforce got to learn how to work in a more efficient manner. And then it was easy to expand from there. I mean, I learned that in my MBA program and my business process classes, which we don't learn in medical school, right, Andre and Andrew? Until you take a business process class, it's an abstraction, right? So the MBA really is helpful for this kind of stuff. But Gary, we'd love to see if we can help you with a project and going after some grant money, perhaps, with you with some of our resources.
So, Vincent, why don't you tell Gary a little bit more about what you've been doing the last couple of years? I know you've worked a lot in the inner city. I know you've done a lot in more like family medicine type things.
Sure. Gary, when I left surgery, I kind of I'm a software developer. I worked into IT business related stuff, and but I've always kept a passion for inner city health. So I did adult medicine. I did a year of internal medicine before I did surgery. So I actually know how to do adult health pretty well. And with the FQACs we're working with now and stuff in New Jersey and other places, we're declaring war on cancer screening, whether it's colon, cervix, breast, prostate, lung, for people living in the inner city who have difficulties not only learning about cancer screening needs, but getting access to getting tested in imaging centers, et cetera. There's logistical problems. It's not just clinical health literacy, it's physical logistics nightmares. So that's a focus that we have, is enhancing communication and outreach, starting with cancer screening for that cohort. And we built a platform that's actually ready to go out and work in that space. So that'd be something, Andre, we could all talk about and see how we can help Gary with some technology advantage.
Yeah, no, absolutely. I'm a little bit more I work with a robotics company. I'm a CMO of a robotics company based in Europe, in Poland, but our investors are in Silicon Valley. And so that's kind of what interested me when you started talking about procedures. What procedures in particular were you kind of wanting to automate? I've seen robots that can do, blood draws or place IVs or things like this. But you mentioned the emergency room, and for a long time I thought the emergency room would be like the worst place in the world to have AI. But actually, as you know better than I do, it's the best place because it's where you can get a rapid response to your question as opposed to other fields. So, but what kind of procedure in particular, you like, low hanging fruit, would interest you? I mean, was it chest tube? Was it EKG? What made the light bulb go off? Or you saw a real
Well, I
need
was thinking.
for it?
Right. I mean, initially, I was just thinking about the simpler procedures, right? So the EKG, not so much the chest tubes, the blood draws, the EKGs, just the things that are so routine,
Sure.
that we're doing really on every single patient as they come in, right? Well, not every single patient. The blood draws definitely, and at least EKGs for the persons with chest X-rays. So just anything that is just so common, it's routine, that if there was a way to at least automate it, that would help. And I'm sure there are other things as well. I just haven't thought much more. You mentioned chest tube. I wasn't even thinking that far ahead.
Yeah.
Right.
So,
Um,
so no, so I'm gonna switch back. So I was looking at the oral insulin, and actually, what it is, it's an immunotherapy to prevent kids from developing type 1 diabetes.
Wow.
There's a
okay.
trial going on with that, and I'm using AI right now to check on those doctors to see if yes. On Friday, five diabetes researchers, I'm using Claude to confirm what I said before. Five diabetes researchers were removed by police from the American Diabetes Association's annual scientific conference in New Orleans after handing out copies of an editorial criticizing I'm afraid to say, the Trump administration's handling of biomedical research funding. So, so there you have it.
Hmm.
So things are getting spicy, getting
Getting
spicy over
spicy.
there. So that brings me to another point. One of the things that I initially liked about the Trump administration is that, and we're going to not talk about politics. Don't worry, Vincent. Um, is how they were opening up AI. They were kind of removing restrictions, which initially I thought was a great idea because otherwise other countries with maybe less noble um, thought processes would get an advantage of us. Now, with time, I've actually come back on it. I've rolled it back and actually think, we need to think a little bit better, have guidelines for the safe adoption of AI in healthcare and in surgery and things like that. But what do you guys think about that? Are you worried, how the way AI can be implemented if it's not done properly? Specifically, Gary, I know you work in the inner city, so you obviously must have quite a few concerns. And then Vincent, I'll let you respond.
Yeah, so I mean, I think there is a role for technology and AI. My immediate concern is, I know before we talked about, or it's been said before about how, profiling, right? So, but that's, I guess that's my biggest concern, just to be sure that we don't use this technology to disadvantage a community that historically has also been disadvantaged. I mean, that's kind of just the top thought. Um, but I would still think, but I would still say embrace technology. I think it works. And as long as we create the guardrails, the policies, the guidelines to kind of help us think through it, I don't see it as a bad thing. With the caveat that just to be sure that we don't end up disadvantaging communities that have been historically disadvantaged. But the way that I think that we prevent that is to be sure that the community that it may affect has a seat at the table. They learn to understand what it is, not only in terms of how to use it, but how to create it as well. Right. So I think we need to shift away from us just being consumers, but we need to be really in the research and development of the product as well. Just not that we're the end user of it, because I think that's the problem. We need to be at the table, involved in the research, doing it, and I think we can better able to shape it so that it doesn't disadvantage some groups.
That's something I have to add. I'm part of a EU grant creating the guidelines for a safe implementation of AI, and that's something that we do in cancer. In oncology, we have a patient representative with all new devices. But honestly, I really kind of hadn't thought about that with AI, and it's in retrospect, we definitely I need to add that to the guidelines, during the creation of it. And if it's not done from day one, guess what? Your algorithm has to go back to square one and has to start over. I think that's at first when you're speaking, I'm like, oh my goodness, how are we going to get that accomplished? But guess what? We'll maybe I'll be able to get it added to the guidelines. Vincent, what are your thoughts? And then our 30 minutes are up. We'll let Gary close us off. But go ahead, Vincent.
Yeah, no, thanks. I was just having a conversation yesterday with someone about kind of this topic in the following way. I think there's been more millionaires over the past 5 years because of AI stocks than probably any time in history. So if you invested in NVIDIA, Google, if you invested in these AI big companies and you have no understanding of AI, but you knew that the trend was good, there are lots of people that made lots and lots of money. If you go to somebody that's making a lot of money in AI stock and you say, you know what, they're not really not very really concerned about governance and guardrails about how AI is deployed. Will you sign a letter with me to see if we can build a consensus to create guardrails around AI? And they go, Vincent, are you out of your mind? I just made $900,000 last year. So the
Yeah.
challenge is the hardest thing to do to have somebody agree with you is to have them give up easy money. And making money in stocks means you didn't do the labor, right? So you're not working for that. The stock went up and you benefited from it, from the bet. So we're at a disadvantage because it's a complicated topic, and we can't even get consensus in our health systems because doctors won't go to meetings with technology vendors and talk about, why did you go with this vendor that has this policy on AI and you didn't come to us? And they said, the business guys go, well, you don't come to any business meetings. You're too busy doing surgery and doing clinical, and you don't know anything about business. So we don't have a seat at the table because 99% of physicians don't have a business degree or a technical degree like we do. And therefore we're at the mercy of management to say, you guys don't get it. We'll call you when we have a clinical question. So we need to get a seat at the table. You're right, Andrew, that without that, it's going to be hard.
Yeah. Gary, before I let you finish it off, it reminds me one of the and again, this is not my idea. I read about this obviously, but one of the powers of the EU are the guidelines, and the easiest way to understand that is the UCB, right? The UCBC. The European Union said, look, stop the shenanigans of keep changing the adapter. We want a USB-C in all the damn phones, otherwise you can't sell in here. So what did Apple do? They changed all of their phones to use USB-C, right, around the whole world. So that's, one of the great powers of Europe. So, maybe by putting in a guideline like we're
Sure.
discussing in Europe, will force, you know, hopefully will force, the rest of the world to behave. But hopefully that's the case. And with that, Gary, please, why don't I'll let you make some final comments if you have any, and then maybe we'll spend the last few minutes just talking offline.
Yeah, I mean, I think I'm excited by AI. I mean, I think that, really we're just at the really the bottom. It's not even at the roof yet, right? So we're just at the entry level. And I think what it can really do for clinical medicine, both in terms of, I'll go back to the patient, the resident, as well as the provider, as well as the healthcare system, it's remarkable. So I'd say I just love it. And the more you kind of read and understand, I think it's really, really good. I think it's good, a good thing.
Yeah, I love your positivity, and I couldn't, Vince and I couldn't agree more. So with that, we'll close episode 92. It's great to have you,
Thank you.
Dr. Rhule, with the one of the greatest last names for a doctor I heard. The only better name I ever heard was a podiatrist called Dr. Dos Remedios. I was like, oh, he doesn't have just one remedy; he's got two. That's the
That's
best
true.
name. But anyway, so anyway, we'll stop recording, and thanks to both of you.
Thank you.
Thank you.
Stay on. We'll talk after. Okay.
Okay.